and in turn you replete K to 4, you replete Mag to 2. And it's something that you kind of learn to do as part of your daily workflow. I would love to hear your general thoughts about this knee-jerk practice of repleting electrolytes.
First, there's almost no data supporting these practices, no strong data, particularly when it comes to electrolyte depletion levels that are like modest. And I would say that there are three things that I'd want people to realize. First, the lack of the data doesn't necessarily mean that we're wrong to give this. It just means that the evidence base isn't as solid as I think some assume it would be. The second is I'd love for people to think a little bit more about why they're doing it. What is the outcome that intern is aiming to achieve other than making the value no longer appear abnormal in the electronic medical record? And then the third thing is I want people to acknowledge that harms of treating do exist, though I admit that they're more related to overtreatment and the things that come with this: time, money, inconvenience for the doctor, for the nurse, for the patient. But these things are not insignificant, right? Time, money, and inconvenience are important.
What is your personal practice for repleting potassium? Are there certain populations that you think about differently than other populations?
I'd start this answer by noting that the normal range of potassium is 3.5 to 5. So what that means is the people who are routinely buffing the potassium to 4 are intentionally aiming for a value that isn't just normal, but is mid-range normal. We don't do that for hemoglobin. We don't do that for most electrolytes. We're not aiming for mid-range normal. We're aiming for low normal. Let's get them to normal. So with that said, my practice is to aim for 3.5. That's the lower limit of normal. And that's true for many of the patients that you mentioned, Ben, including the patients who have acute MI. If the potassium is 3.5, I think it's okay to let that ride. Now, for patients who have a lower risk of ventricular arrhythmia, for example, the patient is admitted with an uncomplicated pneumonia, I don't typically replete if their potassium is 3.2, 3.3. Instead, I check the value again. And if the value remains low, that suggests that something is causing the hypokalemia, and we should try to figure out what that is. Trying to get them to 3.5, because if they have low values on repeated assessments, it suggests that total body stores are probably low. But our attention should be diverted away from just buffing the number every day to asking the question, why is it low, even if it's only mildly low? And I don't know that we do that enough. I think we're good at giving potassium, but we're not necessarily good at asking the question, why is it low?
I really appreciate your point about just stepping back and say, why is this person hypokalemic, and not just reflexively repleting all the time and treating numbers. What is your framework for hypokalemia? When you do step back, how are you thinking about what this person could have?
As with most electrolytes, you can either urinate it out, have it come out through the stool, or it could be shifted into cells. For urinary losses, oftentimes we're doing it to the patient by giving them a diuretic. But you can have RTAs, like type 1, type 2 RTA can cause hypokalemia, okay? GI losses, obviously diarrhea can cause it. Vomiting can cause it through increased aldosterone levels. And then even though you don't lose the potassium with the PPI, the magnesium that you lose with the PPI also then leads to hypokalemia. And then shifts. This ends up being really important when we think about all our patients who are in the hospital with a highly adrenergic state, acute MI, heart failure, alcohol withdrawal. All these are conditions that are associated with increased epinephrine, and that epinephrine is going to shift potassium into cells. Sometimes the hypokalemia is a harbinger of the fact that I'm not treating my patient with alcohol use disorder and withdrawal well enough. It's like looking at the heart rate and the blood pressure. Those are indicators of increased catecholamine. I think so is hypokalemia, although there's a lot of other things going on there.
Is there a number for potassium hypokalemia that makes you pause and you're like, yeah, worried about arrhythmia and all the badness?
I really think this is one of those two-hit hypotheses situations where the hypokalemia alone shouldn't predispose to a ventricular arrhythmia unless it's insanely severe. But even then, you see patients who drop to sometimes less than 2 in there. They don't have cardiac arrest. You need that second hit, which is a myocardium that is sensitive, either because it's had an MI in their scar or because it's got a cardiomyopathy, something else that predisposes to the ventricular arrhythmia. And then the hypokalemia is that second hit, or whichever order you want to think about it. So to answer your question, Trey, if they're less of, I get nervous and I want to give them some potassium, but it really, you have to think about the substrate of that patient and what is that second hit going to be? And a patient who is young and otherwise healthy and has a potassium of 2.8, not running to the EMR to get it into them. The patient who has just had an acute MI and has clearly high levels of epinephrine, that's the patient we got to be a lot more careful about.
What about patients who are aggressively being diuresed?
Yeah, so there's some data for heart failure that maybe 4 is better. But again, these are all observational studies. I think for heart failure, similar to acute MI, if I have an intern who's, let's get them to 4, I have no problem with that. And I often hear the argument, because they have continued losses because of our loop diuretics, if they're 3.5 now, by the time we get to tomorrow, they're going to be 3.1 or 2.9. I buy that.
That was excellent. Thanks, Tony.